Thank you. So good morning, everyone. For our second session, we'll be focusing on joint injections and aspirations with Dr. Torralba. Again, my name is Rumi Ishizawa. I'm the program director here at the University of North Carolina at Chapel Hill. So without further ado, I'm going to hand it over to my co-moderator, Dr. Leah Bettner, who is our second-year fellow here at the University of North Carolina.
Okay, great. So it's my pleasure to introduce Dr. Torralba. Dr. Torralba is the chief of the Division of Rheumatology at Loma Linda University Health in Southern California. She was program director of the fellowship program from 2014 to 2021 and was previously the associate program director at the Los Angeles County University of Southern California program from 2008 to 2012. During her tenure, she was a recipient of the Rheumatology Research Foundation Clinician Scholar Educator Award in 2008. She's been very active with the ACR, serving on the Committee on Training and Workforce from 2018 to 2020. She was part of the group that formulated the ACR MSK Ultrasound Fellowship curriculum from 2017 to 2019, and she's currently on the Committee for Corporate Relations. She's also been chair of the ACR Fundamentals and Advanced MSK Ultrasound courses for the ACR meeting in 2019. She's led the ACR Fellows and Training Principles of Ultrasound courses at the State of the Art meetings in 2018 and 2019. And she previously served as the chair of the US Sonar Advanced Ultrasound course. And as of September 1st of this year, she'll be the president of the Ultrasound School of North American Rheumatologists. So thank you, Dr. Torralba, and we certainly look forward to your talk.
Good morning to everyone. I would like to thank the ACR Committee on Training Workforce for inviting me to be a speaker. I just want to check, you guys can hear me, right? Okay, all right. I do have some polling questions. I'm going to be working with Janet to get those posted. You will have 10 seconds to answer those questions. I saw some questions popping up in the chat, and I will defer those to the moderators to post those questions because I cannot see those questions while I'm talking. All right, thanks. I'll go ahead and start. So I have no disclosures. I would like to start off the talk by saying a big thank you to Dr. Kaylee and Dr. Paul DeMarco, who are my colleagues at US Sonar. You will see as I go along with the talk that there's a lot of information that are ultrasound related. And the objectives today are for everyone, the fellows in particular, to be able to perform common joint and soft tissue injections, recognize the indications for them, and to appraise situations when ultrasound guidance is indicated. I just want to make a disclaimer, this is not a talk on how to do ultrasounds. The only reason I'm putting ultrasounds in my talk is to kind of illustrate a little bit more the process of doing the palpation guided injections, and mainly for you to know when to do the ultrasounds. Just to let everyone know, fellows and attendings alike, this talk pertains to PC5 milestones, and I'm in particular honing in on level 1 to 3 milestones. So I'm going to start off with a question. Go ahead, Janet. Which of the following is arguably the strongest contraindication to arthrocentesis? A, staph bacteremia, B, cellulitis over the injection site, C, INR of a 3.5, D, fracture in the adjacent bone. We'll give you about 10 seconds. Good. So I'm gonna reiterate on this a little bit more in the succeeding slides, but majority got the correct answer. So the indications for arthrocentesis, I kind of like to put it as either diagnostic or therapeutic indications. So definitely for diagnostic reasons, you have a question to ask: what does this patient have? Do they have septic arthritis? Do they have an inflammatory arthritis? They might have crystal arthritis, gout plus septic joint. That's another question to ask. More for orthopedic reasons, they might do it to determine there's a communication between the joint space and the laceration. For therapeutic purposes, especially when a patient has a very large effusion, you might want to do the arthrocentesis for volume relief. Dr. Shakur had talked about muscle weakness. There's some data actually that for a knee arthrocentesis, if there's a very large effusion, it actually inhibits the function of your quads. So for me, in a lot of cases, when I have knee OA patients, they come in with a knee effusion that's very large. I will offer the arthrocentesis partly as a reason to alleviate the pressure in the quads. Definitely for medication administration, whether that's for steroids or a trial of lidocaine or for hyaluronic acid injections. For orthopedics, again, it's for hemarthrosis evacuation. The absolute contraindication, as far as I've read in the literature so far, is still an overlying cellulitis. It is debatable whether a coexisting bacteremia, coagulopathy, or traumatic hemarthrosis are contraindications. But again, just keep in mind that the complications of arthrocentesis, whether or even a bursal injection or aspiration, is going to be pain, infection, bleeding, or allergic reaction. And again, I would encourage everyone to hone in on their informed consent process. So verify with the patient what will be done, how it will be done, why is it being done. If you're going to do ultrasound, explain a little bit further why you're using the ultrasound and what are the risks, which I kind of just explained what the complications are. But in addition, go a further step and tell them, advise the patient on what will be done to mitigate the risks. Like, for example, if you're going to say pain, then explain that you're going to give lidocaine or an ethyl chloride spray. And what are the benefits? This is probably where I spend the most time talking to the patient about, particularly when it comes to injections of steroids for osteoarthritis reasons in the knee. Again, there's a lot of controversy about this, which Dr. Shakur had kind of already explained. I also deal with a lot of osteoporosis, so I do see the effects of repetitive injections even into the joints and what its effects are on bone health. And I kind of explain a little bit more to the patient, like, this is where I want you to be, but if we won't be able to achieve that by using the injections, then we probably need to get an orthopedic surgeon on your case. I kind of go more into detail with that with the patients. When to use point of care ultrasound guided injections. I use an asterisk for point of care. I'm talking about rheumatologists doing the ultrasound in clinic when the patient is there. I'm not talking about sending the patient to a radiologist to do the ultrasound guided injections. There's definitely a lot of literature which shows that there's more outcomes that are better for the patient when done under ultrasound. There's less pain for the patient, definitely for accuracy reasons, and you will see it in the slides I'm going to show you. You might want to do an ultrasound, especially in difficult joints. There might be extra abnormal abnormalities, that doesn't make any sense. There might be additional problems within the joint itself that might make a palpation guided procedure difficult. Obese patients, it's really hard to put a 1.5-inch needle in there. You might end up having to use a spinal needle, a 3.5-inch needle. In those cases, usually I use an ultrasound guided injection. Smaller anatomy, when you're talking about synovial sheaths, injection of the neurovascular tunnels, not into the nerve itself or not into the tendon itself. You don't want to do tendon injections. You want to do peritendinous or perineural injections. I would usually use ultrasound in those cases. So these are the equipment especially for the first years when you get to the clinics, maybe go over these with your attendings. I kind of highlighted here in bold, for fluid aspiration, use an 18 to 22 gauge needle. You kind of have to assess what is the capacity of your hand to be able to do aspirations. If you've never done it before, you might need to kind of figure out how strong your hands are. For me, I'm 49 years old. I already actually have bad osteoarthritis in my thumbs and my PIPs and DIPs. I don't have the capacity to aspirate using a 22 gauge. Sometimes I have to really use an 18 gauge, and I cannot use a 20cc syringe. I have to use a 10cc syringe. So have a better idea of what the mechanics are of your own hands and be able to figure out how you're going to adapt that to doing an arthrocentesis in the patient. So it's just not a matter of knowing what to get from the cabinet to do an arthrocentesis on the patient. Also figure out what's the capacity of your own hands. And again, I'm not going to go into detail with this, but I just kind of put general recommendations for what to do in terms of injections, what materials to use. Again, for perineural tendon sheath injections, you want to go with the smallest needles as much as possible. For simple joint aspirations, depending on the size of the joint, usually I go for 18 to 22 gauge needles. And deep joint injections, this is kind of where it gets a little bit dicey when you're having to use a spinal needle on a much bigger patient. Same thing with the steroids. I kind of just summarize what is in the literature and I put it here. Smaller joints, you might get away with 10 to 20 milligrams of steroids. Again, have a discussion if you're attending about that. Larger joints, intermediate to large joints, 40 to 80 milligrams. For anesthesia, I sometimes offer the patient both options, or I tell them, if you only want the spray, I'll only give you the spray, the ethyl chloride spray. Or if you want an additional anesthesia into the skin, that will entail an additional injection technically. So some patients will say, oh, I just want the spray, I don't want the extra needle, and they're fine with that. So this is the general technique. I'm gonna show you some slides further just to explain this a little bit further. Within the context of knee injections. So knee injections are probably going to be the most common injections you're going to do as a rheumatologist. It's probably the number one it's number one joint injection you have to master early on during your fellowships. So my next question is this: which of the following is the main surface anatomy landmark for knee injection? Is it the quads tendon insertion onto the patella? Is it the superior and posterior surfaces of the patella, the femoral condyle articulating with the tibia, or the medial tibial plateau? Okay, everybody got this correct. So let me explain a little bit more. The quads tendon insertion on the patella, if you're interested in psoriatic enthesitis or any form of enthesitis, you might consider injection in that area. So that would not be the landmark for a knee injection. For a knee injection, you really want to localize the patella itself, particularly the half to upper third of the patella. And if it's not a very large effusion, you can direct the needle towards the joint space, so going more medial into the middle of the joint. If it's a larger effusion, you can just go horizontally. Femoral condyle articulating with the tibia. This is one thing I kind of realized when I started doing ultrasounds in 2008, that all the knee injections we were taught during my fellowship and even before that, you're technically accessing the suprapatellar recess in most cases, not the joint space per se. And definitely you're not going to target the medial tibial plateau, which is kind of the same answer as C. So let me move forward. So again, the approach is going to be medial lateral. This is what I was talking about earlier. The approach really is to target the suprapatellar recess underneath the patella. Same thing here. Again, for aspiration, you want to probably use a 22 or 18 gauge needle. You want to put your thumb on the patella and kind of push it aside. So you want to make your markings maybe a centimeter above the patella and a centimeter below the patella. And then kind of just put your finger there and put the mark on it. The person on this slide is actually putting an X over it. What I usually do are the crosshairs. So when I clean off with an antiseptic, it doesn't get erased. So if the crosshair is here, I just clean the inside of it. I still have the crosshair markings to show me where to go. So that's just a tip I've realized over the years. So you would definitely want to define your joint anatomy, position the patient. So for a knee aspiration or injection, some people prefer to do it with the knee extended. Some people prefer to have the knee maybe with an angle of 20, 30 degrees. They'll put a towel or a gown underneath the knee. I prefer putting a towel or underneath the knee with the knee flex a bit, like about 20, 30 degrees. Then you apply your antiseptics or drapes if you want, and then you apply a wheel over the knee. So with, this is a smaller gauge needle. So this is about a 27 gauge needle. This is 25 actually. And you put a wheel into it. And then you switch out the needles. Again, this is a second needle injection. You then insert with an 18 or 22 gauge needle over the site where you put the wheel. Then while aspirating, start pulling back on the plunger. Start applying pressure on the opposite side of the knee. If you're gonna give a steroid injection, for example, usually I will tell the fellow actually at the very beginning of the procedure, do not pull out the needle, whatever the case may be. And then once they get to this point that they've actually put in the needle, they've avoided the bony landmarks as they're going in, I tell them to unscrew the syringe and then use the same needle to attach a syringe with the steroids in it. So that basically takes care of the knee joint aspiration. You just pull and withdraw the needle slowly, apply pressure, then clean up the patient, put the Band-Aid on. And that's basically it. But when would I decide to do an ultrasound-guided knee aspiration? In fact, in a lot of cases, payers will not pay for ultrasound-guided knee injection unless there are indications for it. So usually the indications are a failed palpation-guided injection or aspiration. When the patient also has a very huge BMI, they're very obese, and it's almost impossible to do a palpation-guided injection or aspiration, that's another indication. If the patient has very unusual physical deformities, they may have contractures or some other problem, that's another indication to do ultrasound-guided knee aspiration. In some cases, I'll just throw on the ultrasound. Some patients like the assurance of knowing the needle is actually going in there. I'll also do the ultrasound. So, so that's for a regular knee injection. But what about popliteal cysts or Baker cysts? So these are done at the back of the knee. The patient's usually prone with the knee extended. I don't usually do these under palpation guidance. I'll do it under ultrasound guidance. And for all the ultrasound views moving forward, I'm just showing one approach. I'm not showing more than one approach just to make the lecture simpler. So for this particular approach, this is being done in a longitudinal approach from distal to proximal, and it's pretty easy to access the popliteal cyst at that point. The reason why I would probably encourage an ultrasound guided injection is you really want to avoid avoid hitting the neurovascular bundle, which is kind of just lateral to the Baker cyst by about 1 or 2 inches. You also want to make sure you're not hitting a popliteal aneurysm. So that's the other value of doing an ultrasound guided injections. When you throw on the color power Doppler on over this Baker cyst, and then you notice that it becomes red or whatever color it is in a color power Doppler, that's an aneurysm. You do not want to put a needle into an aneurysm. So that's it for knee injections. We're going to move on to shoulder injections. So this is my next question. Which of the following is or are the landmarks for a posterior shoulder or glenohumeral joint injection? A, medial to humeral head and inferior and medial to the posterior lateral acromion. B, medial to the humeral head and inferior and lateral to the coracoid. C, superior to humeral head and inferior to the acromion. And D, posterior lateral edge of the acromion. Okay, so there are some clarifications that need to be done here. The correct answer is actually C. B, sorry, it's B. It's medial to the humeral head. You have to put that in, and inferior and lateral to the core. Sorry, this is the posterior approach. So the correct answer is going to be here. So this is the correct answer here. It's medial to the humeral head and inferior and medial to the posterior lateral acromion. The other answer, which is going to be letter B, that's actually the anterior approach. So the coracoid is in the front. Here in the back, you're actually accessing it under the posterior lateral acromion. So this is the correct answer. The other two answers actually pertain to the supraspinatus bursal approaches, and I'm going to explain that further. So for a glenohumeral joint injection, Again, you want to localize it medial to the humeral head. That's probably the most important thing, especially when you're palpating. That's the first thing I actually tell the fellows is actually localize the humeral head and just palpate medial to that. That's probably going to be the best landmark. You have to realize, so we cannot talk about the joint without talking about the bursa. The bursa, actually, the subacromial subdeltoid bursa, or SASD bursa, which is what we call it, does drape quite significantly over the anterior portion of the glenohumeral joint. It's a little bit more limited over the back. So this is your coracoid process going over here. You want to access it over in this space below the coracoid on the anterior approach. Again, on X-ray, this is kind of what it's going to show. For the posterior approaches, you technically are going to go under the, you're going to go under the coracoid. So you really want to palpate the coracoid. You want to palpate the spine of the scapula. And once you reach more or less the area of where the humeral head, then put your thumb below that. And that's going to be your approach. When we do it under ultrasound guidance, technically what we're doing is actually inserting the needle into the supraspinatus. So this is the supraspinatus, this is the glenohumeral joint here. So just to let you know, again, for some patients who are bigger, you cannot really see clearly where their humeral head ends and that sort of thing by palpation guidance. You want to do it probably under ultrasound guidance. So it's very clear when you're doing under ultrasound guidance, once you've adjusted your depth, that this is quite accessible by ultrasound guidance. Subacromial subdeltoid bursa, or SASD. So technically, when we do the ultrasound, this is the deltoid bursitis, subdeltoid bursitis in this patient. Technically, this is not distended when there's no fluid. So when we're approaching the subacromial subdeltoid bursa, if you're doing it under palpation guidance, you can do it posteriorly under the posterior acromion, posterior lateral acromion. That's why D is the correct answer if I was asking about the subacromial deltoid bursa injection. You can do it also laterally, just going under that bony process over here. For ultrasound guidance, there's different approaches again. A lot of us probably will just do a coronal view of the shoulder and just insert the needle underneath that. So when doing an ultrasound, so this is where the needle goes. In my personal opinion, I just do my subacromial subdeltoid bursa injections largely by palpation guidance. Again, you know, if there's problems with anatomy, locating anatomy, then I will do it under ultrasound guidance. Biceps tendon injection, for palpation guided approaches, you would like to locate the tendon in the groove, insert the needle at 30 to 45 degrees superiorly into the sheath. That can be very difficult to do. If you really want to hone in on the accuracy of your injection, again, ultrasound guidance would be ideal. There are different approaches to this. This is the transverse approach, and you can basically just put the probe over a transverse axis over the bicipital groove, and then approach with the needle going from lateral to medial. And you're not doing a peritendinous injection. You should not do a tendon injection. You should do a peritendinous injection just within the sheath. Again, for accuracy purposes, I would probably do a ultrasound injection for this reason. The other thing you want to avoid when doing a biceps tendon injection is to avoid the circumflex artery. You also want to avoid an intertendinous injection because there is a risk of rupture. So again, depending on what you want to do with the patient or what is the current clinical scenario of the patient, you can decide between doing a palpation guided approach or an ultrasound guided approach. The AC joint is quite accessible. So in a lot of cases, you don't need an ultrasound for this. So the patient might be supine, or in this case, seated. The affected arm is resting at their side with the elbow kind of cinched towards the waist. You want to palpate the clavicle distally to its termination and feel for that depression. Again, just realize the AC joint is very small. It's not very distinct. And you can basically just approach it with a needle, either perpendicular or a little bit angled by about 20, 30 degrees over it. Under ultrasound guidance, again, for accuracy reasons, you can approach it quite easily. You do not want to inject into the disc itself because you can cause a secondary osteoarthritic process to ensue. Elbow injections. So here's another question. For injections targeting the common flexor tendon, the point of maximal tenderness should be located. What is the key anatomic landmark for needle insertion? Again, this is the common flexor tendon or the common flexor tendon insertion. So A, posterior to the medial epicondyle, B, over the lateral epicondyle itself, C, 4 centimeters distal to the lateral epicondyle, or D, over the medial epicondyle itself. Okay, so the answers are quite spread out, 30% each for answer C and D. So I'm gonna explain a little bit more. So you have to go back to your anatomy and ask yourself, where does the common flexor tendon attach? So common flexor tendonitis is, in layman's terms, golfer's elbow. So you have to ask yourself that question. I'm gonna get to the answer in a moment. So for elbow injections, aspirations, I'm just showing the palpation guidance here because the ultrasound guidance is a little bit, it's actually a lot different. So for palpation guided injections, approach is lateral. You have to find a triangular area between your olecranon, radial head, and humerus. You wanna find the midpoint in that, the depression within those three structures. And then you can approach the needle, like in this case, it's actually directed towards the medial epicondyle. If you think about a line, a vertical line attaching your lateral and medial epicondyle, and you can aspirate the elbow from there. Don't be fooled, this patient also has an olecranon bursitis, but I guess the patient has both a elbow joint problem and an olecranon bursal problem. For the lateral epicondyle, so just to clarify, if you do your anatomic positioning, extensor tendon is going to be on the external part of your elbow. It's going to be the lateral epicondyle versus the medial epicondyle. This is going to be where your common flexor is going to be, and that's your golfer's elbow. The correct answer is you have to palpate for the point of maximal tenderness over the lateral or medial epicondyle, depending on what you're trying to approach. If you're trying to approach the common extensor tendon, then it's the point of maximal tenderness over the lateral epicondyle. If it's over the common flexor tendon that you're trying to address, then go and inject the point of maximal tenderness over the medial epicondyle. So the correct answer there would be directly over the medial epicondyle. The absolute incorrect answer is going behind the epicondyle on the medial side, because you do not want to do that because you're going to end up injecting into the ulnar nerve. And you might cause a traumatic cubital tunnel syndrome. So again, medial and lateral epicondyle injections, you have to palpate the point of maximal tenderness over the epicondyle itself and inject over there. Do not inject posterior to the medial epicondyle because that's where the ulnar nerve is. So there was a question that came up when I gave this lecture recently, whether should you do a shallow injection or a deep injection. So this is somebody doing a lateral epicondyle injection. So far, based on the ultrasound literature, it's still not decided whether it's more feasible or more effective to do a superficial or a deep injection. But either way, you can do this. Dr. Shakur had kind of talked about PRP injections. That's very much in vogue among our orthopedic and physical medicine, sports medicine colleagues. I've done it myself in a few cases. I'm not endorsing anything, so I'm not going to say whether I endorse it or not. But you can do different approaches with the epicondylar injections. Olecranon bursa injections, again, this is quite common. Usually, again, for olecranon bursitis, the elbow joint range of motion is going to be normal. If it's an elbow joint problem, the range of motion usually is affected. So for olecranon bursa injections, you want to have a landmark 1 centimeter distal to the olecranon bursa. You want to do a series of needle passes if the fluid is located. So usually in that case, when I've done already a palpation guided or blind procedure doing an olecranon bursal aspiration in the patient, I don't get anything, I grab the ultrasound and then I try to localize where the fluid is. So this is an ultrasound guided injection here, and it's pretty clear where you're gonna go with it. The patient only had a very small sliver of fluid, if you noted at the beginning of the ultrasound. Hand and wrist injections. So we're kind of flying through this. So this is another question. Which of the following is a key landmark for radiocarpal injections? So A, palmaris longus, B, the anatomic snuff box, C, the radial artery, D, the Lister's tubercle of the radius. So it's asking for the key anatomic landmark. What are you going to palpate for to know that you're going to get into the radiocarpal joint? Good. So majority, 66% got the correct answers. So if you've never palpated for your Lister's tubercle, you can palpate for your own Lister's tubercle right now. It's quite palpable. This is your anatomic snuff box. Again, I'm not going to go into the ultrasound anatomy because that's going to get very complicated easily. So if you just do this, I have a very fat hand, and this is what also Dr. Shakur was talking about earlier. It's hard to do examinations sometimes on people with fat hands. I'm one of those. So if you do this with your thumb, kind of abduct and hyperextend it, you can make your anatomic snuff box more visible. You just go to the base of that and go distal to your radial styloid. You're going to enter your radiocarpal area, or radioscaphoid joint also is what it's called. So 1 centimeter distal to the Lister's tubercle at the distal end of the radius and scaphoid base. You can do it quite vertically, like in this picture. Under ultrasound, we usually do it longitudinal, like in this approach, or transverse. Again, if you want accuracy, if you think somebody has RA and you're not sure, is it the radiocarpal joint or the intercarpal joint that they're having a wrist joint inflammation in, you can throw the ultrasound on and localize where you're going to inject. IP, interphalangeal, or MCP joints, it's quite simple. It's a dorsomedial or dorsolateral approach. You can try pulling on the joint kind of for traction to make it open up. It's the same approach you would do with the other joints in the foot, the IP and MTP joints in the foot. Again, you want to have the patient really relax for this. Personally, I don't do a lot of these anymore. I used to back when in the early biologic era, but maybe nowadays with better drugs, we're not doing a lot of these anymore. Flexor tendon injections. I do majority of my flexor tendon injections under ultrasound. I guess, again, technically it's an accuracy issue, but if you decide to do it under palpation guidance, you really want the patient, again, relaxed, the arm and hand is extended. You're technically just going in with a very thin needle, sometimes even shorter than a 1.5-inch needle, with the needle almost laying flat against the skin. In my experience, when I started doing ultrasounds, I realized that maybe most of my palpation guided injections were actually going into the tendon. But again, with accuracy being of importance in these, with these issues, I usually do them under ultrasound now, and this is a transverse approach with an ultrasound guided procedure. This is another question. For Dequervain's tenosynovitis, which of the following is the anatomic landmark for injection? Is it A, proximal to the pisiform, B, palmaris longus, C, palmar surface of the second MCP joint, or E, the radial styloid? So everybody, almost everyone, 65% got the correct answer. Palmaris longus, you're gonna realize in a little while, it's the landmark for something else. So I'm gonna show you that. The palmar surface of the second MCP joint is the landmark for your A1 pulley injections when somebody has, like, let's say a trigger finger of this second finger. So let me go ahead. So again, Decker vein syndrome, again, when you're doing that motion with the extension and abduction of your thumb, your Decker vein tendons, the APL and EPB, are actually your extensor compartment 1. So it's kind of like the radial edge of that triangular anatomic snuff box. So once you've located those tendons, you want to palpate to the radial styloid and then approach with the needle about 3 centimeters at the base of the first MC, 3 centimeters proximal to the base of the first MC. You want to go in a proximal, from a distal to a proximal direction, kind of aiming towards the elbow. If you feel resistance, you probably have hit the tendon. Again, we encourage not hitting the tendon itself, but doing a peritendinous injection. So in these cases, you know, it's boxed out here. You want to do, you might want to consider doing an ultrasound in short axis, ultrasound guided injection. Carpal tunnel injection. So this is where the other answer is going to come in. This is where you locate the palmaris longus, particularly at the palmar crease, the proximal palmar crease. You can try and locate the palmaris longus a little bit more by doing resistive flexion of your third finger. You want to approach the carpal tunnel or the nerve, do a perineural injection ulnar to the palmaris longus at the crease at the 20 to 30 degree angle. It's said in the literature 2 centimeters deep, but then again, when I've started doing ultrasound, it's probably a lot less than that, maybe only 1 centimeter. So this is under ultrasound guidance. This is one of the more common questions we get about ultrasound guided injections. You do not want to inject the tendon. You do not want to inject any of the nerves or tendons in this area. So it's very easy to locate the median nerve. So this is it. This is the median nerve in short axis, and this is the median nerve in long axis. So this is a short axis approach to an ultrasound guided carpal tunnel injection. Again, just to illustrate the accuracy of doing it under ultrasound. First CMC joint, so a lot of women, they'll start developing CMC joint OA in their 40s, depending on what job they're doing in particular. You wanna ask them about that. You wanna have the thumb flex across the palm, approach the base of the first MC at the distal end of the anatomic snuff box. So it's quite accessible. Usually I do most of my injections under palpation guidance first. Unless the patient keeps on having pain, then I might want to bring them back for an ultrasound guided injection. Hip injections. Just want to double check. So the last time I've seen somebody doing a palpation guided injection in clinic was probably during my fellowship. I did my fellowship at USC County, and Dr. Ersman would sometimes go in there and do hip injections on patients. I've done it probably once or twice in my whole career, but ever since doing the ultrasound guidance, ultrasound courses and all of that, I've started doing everything under ultrasound guidance. It's quite tricky, especially if you're talking about really big, high BMI patients. It's hard to palpate for the hip joints. So even in the radiology literature, they actually recommend doing this under ultrasound or fluoroscopy. If you decide to do it under palpation guidance or blind, you want to palpate for the femoral neck, insert the needle along the femoral neck, anterior or just inferior to the greater trochanter. When we do it under ultrasound guidance, it's pretty straightforward. The patient's lying supine, the foot is externally rotated. This is a hip joint effusion here. So this is distal, this is proximal, so this is towards the head. This is the femoral head here. Normally, this is not going to be tented when there's no effusion. This is going to be laying flat against the capsule will be laying flat against the bone, but this is somebody who has an effusion. So this is somebody doing the injection, and basically the target point will be the femoral neck. You don't want to be down here. You don't want to be above here. You want to give it at the femoral neck region. And this is somebody who also threw on the color power Doppler to guide the direction of where the needle's actually going. And once they put in the injectate, the steroid, it's also going to light up. So there's a lot of clarity when it comes to doing the ultrasound guided hip injections. So I have another question. So which gluteal tendons attach to the greater trochanter of the hip? A, is it the gluteus medius and minimus and maximus? Is it B, gluteus minimus, medius, and maximus? C, gluteus medius and maximus? Or is it E, gluteus minimus and medius? So it's kind of spread out, but 44% got the correct answer. It's gluteus minimus and medius. The maximus doesn't attach to the greater trochanter. So the gluteus minimus attaches the anterior facet of the greater trochanter. The gluteus medius attaches the lateral and superior posterior facet of the trochanter. So moving forward, once people started doing ultrasounds of the hip for bursitis, it was established about 10, 15 years ago that bursal distension is actually rare. And a lot of the trochanteric bursa designated patients were actually patients who had tendinitis, either of the minimus or medius. For palpation guided injections, personally, I actually do the injections in the most part by palpation guidance. Some of the literature has shown that even if you inject into the tendon, similar to the lateral epicondyle common extensor tendon injections, there isn't a lot of trauma, even if you inject at the insertion site. I would probably only do ultrasound guided if it's somebody, again, with a high BMI. So again, bursal distension is rare. The arrow here, thick arrow here, is the potential space for a greater trochanteric bursitis. The thinner arrow is somebody who might have a subgluteus medius bursitis. This is actually somebody who has a subgluteus medius bursitis, and injection is actually inserted into that space. So just letting you know, bursal distension at the greater trochanter is rare. I threw this in because this is a very common injection question I get. For SI joint injections, we highly recommend a fluoroscopic or ultrasound guidance. We actually recommend a long spinal needle. We actually recommend that the lower part of the joint be accessed along the second foramen. So doing it under palpation guidance might be a little bit tricky. So we highly recommend doing it under ultrasound guidance. Ankle and foot injections. So I have another question. This is probably my second or third to last question. What are the anatomic landmarks for palpation-guided tibiotalar injections? So tibiotalar, A, lateral to the tibialis anterior and distal to the lower margin of the tibia. B, lateral to the extensor hallucis longus and distal to the margin of the fibula. Or C, medial to the tibialis anterior and distal to the lower margin of the tibia. E, medial to the extensor hallucis longus and distal to the lower margin of the tibia. Go ahead, you have 10 seconds. So a lot of you guys got the correct answer. So the correct answer is medial to the tibialis anterior, distal to the lower margin of the tibia. So there are a lot of joints in the foot and the ankle. For palpation guidance, you might want to have the patient a little bit slightly plantar flexed. You want to go anterior medial approach. So your needle is going to insert medial to your tibialis anterior. So if you look at your ankle, you kind of dorsiflex. You're going to make your tendons a little bit more prominent. The one that's most medial is going to be your tibialis anterior. And so you just insert the needle in there. You kind of direct the needle kind of towards the other the lateral malleolus. Sometimes if you draw a line from there, but basically you're directing it posterior and laterally with a depth of about 1 to 2 centimeters. This kind of corroborates with one of the ultrasound guided approaches. We do it under transverse view. Again, very approachable. Personally, I've encountered a lot of palpation guidance, guided tibutalar injections where I then realized the patient actually didn't have an effusion, and I'm trying to suck fluid out of there and I'm not getting anything. And then I throw the ultrasound on only to realize, oh, they didn't have effusion. A lot of times I might not be doing it under ultrasound guidance, but I am doing a quick survey of the ankle joint just to see if they have an effusion to begin with. These injections are quite painful. So that's why I do the ultrasound viewing first, but with the option of doing the aspiration under ultrasound guidance. Subtalar joints, this is going to be of interest a lot more among the pediatric population, but I would encourage a lot of adult rheumatologists to actually look into this a little bit further. It's actually quite accessible. A lot of effusions actually occur in this area. It's approachable from both the medial and lateral approach. Basically, you just palpate the distal point of either your lateral or medial malleolus, and there's going to be a depression there, and that's your subtalar joint. Again, it's very accessible whether you do it under palpation guidance or ultrasound guidance. I kind of already mentioned this before, MTP, IP joints of the foot. The approach is similar to the hands. You do it either dorsomedial or dorsolateral. Tendon sheath injections, again, very similar in approach compared to that in the hand. You can do extensor tendon injections, sheath injections. Again, for more accuracy, you might want to use an ultrasound to make sure you're not injecting into the tendon and just around the tendon. Just to let all the fellows know that there is a high incidence of ruptures of tendons, plantar fascia when doing injections. I actually take the further step of putting the patient in an AFO and ankle foot orthosis for about 2 weeks and advising the patient and documenting this in the chart that I've told them to use the orthosis as much as possible. They can remove it when they're taking a bath, but they use it for a minimum of 2 weeks and to avoid any strenuous activity with the feet, like running or jumping or whatever. So that's basically it. When it's done under ultrasound approach, you just do a peritendinous injection. Plantar fascia, you basically locate the needle at this space, this corner between the calcaneus and the fascia itself. We do not recommend actually injecting the fascia itself. Again, there's a high risk of ruptures. Somebody might also ask about Achilles tendon injections. I also do it in that space in front of the tendon, but in that small space where potential some fluid might pop up, but very rarely so. But I don't inject the tendons per se or the fascia itself. So again, I usually do this under ultrasound with advice to the patient to use a AFO. So how would you document your procedures? The same thing, I would encourage you to put in there what you wrote, what you advise the patient for as part of your informed consent process. But these are kind of the basics of what's supposed to be in your documentation. These slides will be provided to you. I also did like a draft of a procedure note here if you want to use it. And if you do something, you document it, and you need to be paid for it. So this is my next question. A 26-year-old female with RA comes in for her regular visit for RA. Is seen by the first-year fellow with the attending, noted to have a swollen elbow, and undergoes a joint injection. What billing code should be filed? A, CPT means common procedural terminology, so it's the codes for all the procedures. CPT 20605, modifier 25, modifier GC. CPT 20606, modifier 25. C, CPT 20606, modifier GC. D, CPT 20605, modifier 25, modifier 59. So it's an RA patient coming in for her regular visit, seen by the fellow with the attending. And then an elbow injection is decided to be done at the same visit. All right, so 41% got the answer correct. It's A. So let me explain. Modifier GC, if you're seeing a patient with attending, that's automatic. So all the fellows remember that. With an attending, GC. If you're seeing the patient and then deciding to do a procedure, you have to put in a modifier. So let me go through this. Palpation guided procedures, just remember all the procedures starts with a 206, but if they're palpation guided procedures, small, medium, large joints, 0, 5, 10. Modifier 25 is done in the same day. So this patient had the palpation guided procedure on the same day for her regular RA visit. So the correct answer is elbow, because that's an intermediate joint. The correct answer is 20605 with a modifier 25 plus a modifier GC, because you've seen the patient with your attending. If you decided to add on a hip injection, that would be a second procedure. Then you also throw in modifier 59. I would encourage everyone to talk to their coders. If it's an ultrasound guided procedure for an elbow, then you make it a 20606, put in the 25 again, and put in the modifier GC. All right. So again, remember everything starts with 206. It's 0, 5, 10 for blind. It's 4, 6, 11 for ultrasound guided. Put in your modifier 25 and a GC for your attending. Take-home points, palpation and ultrasound guided procedures are useful skills. Joint soft tissue injections, aspirations have diagnostic and therapeutic purposes. And these are my references in addition to the ones I put in the slides. If anybody has any questions, I'd be happy to entertain them right now.
Thank you, Dr. Torralba, for your very informative lecture here on all the different approaches for all the different joints. One of the things I was wondering about is sort of what is your approach into offering to do a therapeutic injection in particular? I had an attending when I was in training, Dr. Ron Anderson, and he always used a comment to extend the needle of friendship. So what are things when you're assessing a patient that makes you, strongly offer a therapeutic injection to extend that friendship with the needle?
So I'm actually very conservative with steroid, just plain steroid injections in general. In fact, I encourage the use of ancillary allied health professionals first. So for example, I would encourage the use of, let's say that we're talking about carpal tunnel. I would encourage bracing, OT, lifestyle modifications, that sort of thing. They might have an endocrinopathy that might need to be addressed. If they have RA, well, I tell them I'm not going to do injections. It's kind of useless if you don't control your RA first. So I do the more conservative stuff first before I actually do the injections. A lot of times what I notice is that, for example, I get a referral from another attending who wants me to do an injection in the patient. A lot of times I'm actually at odds with that attending, because I think you have to exhaust the conservative approaches first, because the literature technically about the efficacy of injections, whether it's blind, if you start first with blind or palpation guided evidence that it's efficacious, there's a lot of kind of ambiguity whether doing an injection first is going to be useful versus doing the conservative approaches first. So I kind of reserve doing the injections last if everything conservative doesn't happen or it's not successful.
Right.
Thank you, Torralba. I also have a question. You kind of got into this when discussing hip, sacroiliac, and kind of the small tendon or peritendinous injections. But I wonder, with the increased use of ultrasound overall and the fact that we can essentially use it for every joint, are there certain or other injections that you think warrant the use of ultrasound guidance just from a safety standpoint when thinking about areas of higher risk anatomy?
So your question is, are there other areas that I might not have mentioned today that would warrant the ultrasound guidance?
Yeah, aside from like the hip and the sacroiliac and more of the small peritendinous areas.
Yeah, so my other disclaimer for this talk, I actually started out with 100 slides. I had to cut it down by 40 because of that question. So there's a lot of things you can approach by ultrasound guidance. Let's say you want to, so once I started doing ultrasound, I started getting more interested in PM&R approaches and that sort of thing. So you start looking at sacroiliac dysfunction or scaphoid dysfunction. You can also approach the infrascapular area with an injection. There's actually a bursa there. You also can start doing TMJ injections. A lot of times it's accessible by palpation guidance, but I find that using ultrasound actually makes me localize where the nerves are and where the blood vessels are, and I want to, start avoiding those things. So those are a couple of joints I would encourage doing ultrasound on. Anything that starts approaching the spine or anything that starts approaching a tendon or a tendon sheath or a nerve, I would encourage doing ultrasound. Actually, for all my hand injections, I actually do them all under ultrasound now.
I have one more question for you, Dr. Torralba. In terms of after you've completed an injection for a patient, what are some of the things you counsel the patient about? You mentioned like for when you did the feet, you keep them sort of in a boot and tell them to limit their activity. What are sort of your general sort of information guidance you give to your patients after procedures?
I also tell them to put ice pack on the injection site for about 40 minutes when they get home. Again, for about 24 hours, avoiding any strenuous activity as much as possible. But I also tell them this is not going to work if you keep on doing the same things that's made it happen. So, you get these patients, you just don't listen, or, they might be in a situation where they can't change your job. So a lot of times I might actually even go further and ask the OT to do a vocational rehab evaluation on the patient. Sometimes it's not the patient themselves doing something. You have to have an allied health professional look at their workspace to help, make the injections a little bit more efficacious. The other thing I actually do is I time the injection, doing it before they go back to the therapist. And sometimes for me personally, I don't have the data, in fact, to say this is true or not. I feel that the patient can tolerate the therapy a little bit better sometimes if they have the injection beforehand as a pain control measure.
Great, wonderful.